Hi everyone, welcome to our Unit 6 discussion here in ST-135. Today we're going to be talking about robots, different robotic equipment and endoscopic equipment. They are slightly different in the two, but they do go together pretty well. So the objectives for this week are to learn about those robots and how that applies to you as a surge tech, as well as how robotics impact the world of endoscopy and how it's changed, and what you need to know and prepare for as you go into the operating room that may utilize a robot. So here are your assignments for this week. Remember, you've got your normal discussion post, a case assessment, and then a couple quizzes. So it's not a whole lot this week. It's pretty light, but I want to give you a heads up as to next week because this is starting to wrap up our quarter, okay? So Unit 7 is our last full week of assignments because Unit 8 is more of a wrap up. It has just a couple small assignments. It's actually like half a week. So Unit 8 is not a full week. So I wanted to give you this heads up that you get these bigger points, these comprehensive knowledge checks to realize it, final exam. Get those points in because those are big items right there. So just to give you a heads up, plan accordingly so you don't get caught off guard, okay? So what do we need to know about robotics or endoscopic equipment? So I like this first little thing here. It says, did you know that laparoscopic surgeries started actually in 1901 and the first robotic surgery was in 1985? So that's all in the grand scheme of medicine, it's not that long ago, okay? But I guess in our lifetime, it kind of is a long time ago, right? But 1901 is really not that far. Um, but we've come a long way, I think, in the last 120 some years, right? The first laparoscopic surgery was actually performed on a dog. A surgeon was um, just, trying to learn and did a laparoscopic surgery on a dog. So I thought that was kind of interesting. And it just kind of went from there. Robots have while they were developed in the 80s, I think within really the last 15 years have just exploded. It's become a huge part of surgery. Even in my smaller area, my rural areas, they almost all of our hospitals, even if it's only a 5-hour hospital, has a robot now. So it's become pretty common, pretty mainstream for most facilities to at least have one surgical robot, with many facilities having multiple. So here are your surgical robot systems. I would say the most common is the Da Vinci. It's still the Da Vinci system. That was kind of the first big name that's kind of stuck there. A couple different designs since those have come out, but the Da Vinci still kind of, I think, rules. But you have Versius Enhance, joint arthroplasty systems, and then a Monarch platform. So here's what they look like. We're going to show you a couple pictures about those. These are the arms that hold the instruments. So get into some of the components here. This is how it would be laid out in the operating room. So if you're curious like how that is positioned next to the patient, it does look pretty, kind of pretty bizarre. From above, it almost looks like a spider or something. It's really weird. But these are the arms that hold the instruments, these endo wrist instruments. The thing that is holding all that together, that's positioned next to the patient, is called the patient cart, or it is sometimes referred to as the bedside unit. Okay. Then you have it hooked up with various cords, so you have a picture that the entire operating room can see, the vision cart. You have anesthesia at the head of the patient, obviously. The assistant, and where it says nurse, that's really you, the surge tech, the surgical technologist, surgical first assistant, maybe a PA, something like that. Up here at the patient, assisting as necessary, maybe changing out these endo wrist instruments as needed, having those available. So the surgeon is not up at the patient for robotic cases. They are sitting at a console, the surgeon console. Now, more often than not, that console is in the operating room with the patient. But what is interesting about robots is that the surgeon could be in another country and still able to perform the surgery. It's called telesurgery, teleoccur. Okay, so that surgeon would be at a different console, but dialed in somehow, crazy technology, to this particular robot. Now, I believe that a surgeon still has to be available here if something happens and goes wrong, and maybe they need to open the patient. So there is still a surgeon available. It's just not the surgeon that's doing the performing. So inside this console, as the surgeon sits there, they've got their hands and fingers in these little, they look like contraptions, I guess, but that's what is controlling the ends of these instruments, these endo-wrist instruments that look like laparoscopic instruments. Now, it says that these instruments are designed with what's called 7 degrees of freedom that mimics the same movement of your human wrist. So it's not just a straight stick, so to speak, like your laparoscopic instruments. The ends of these can rotate and move up and down, left, right. So that's the benefit. You can do a lot more, you have more degrees of freedom to manipulate things. So it's pretty cool. So pros and cons, it's not going to be good for every single patient. That's going to be up to the surgeon and, patient anatomy, even patient wishes. Some are still pretty much against it. Some are okay with it. So, well, that goes into play. So pros would be the images in 3D. So that's really cool. It's really a much better picture. Faster patient recovery because typically the incision sites are smaller. There's less manipulation of tissue. So reduces tremor and movement scale when the surgeon has their fingers in those things at the console. Telesurgery is possible, like I said, and it closely replicates human movement as opposed to your laparoscopic instruments that don't. So some of the cons, some of the bad things, I guess you could say, would be maybe no tactile feedback, but I think this is changing from what I've heard. I don't scrub robotic cases, but this is something that I think has changed. So that would be very beneficial. They are super expensive. There's no getting around that. That piece of machinery is millions of dollars. So, the price of the actual surgery might be more expensive to replicate, to accommodate for that. Does use valuable resources, those pieces of equipment, those arms, all of that, the drapes, etc., are all expensive to go with it. Does require an on-site coordinator and special training for the team. So you can't just walk in there and expect to know how to drape it, how to dock it, all of those things. It does take some training. So here's a quick little video I wanted to show you on the Da Vinci, since that's one of the more common ones, showing this robot in action, if you've never seen one.
Hi, my name is Matthew Sappington. I'm a general and bariatric surgeon here at the Kansas City VA. This is our Da Vinci robot that we've recently acquired here at the Kansas City VA. Essentially what it allows us to do is, while we sit at this console, we're controlling the different arms of this machine. And through doing that, it gives us more flexibility in how we operate as laparoscopic or minimally invasive surgeons. With the addition of the robot, we have the ability to essentially use the tools as though they have a wrist. And whenever we start the case, it starts very similar to our regular laparoscopic surgeries. But once we're on the inside, we have much more functionality to our hands. And so one of the things the robot adds to sort of our repertoire here is that it will give us a chance to do more of our operations in a minimally invasive fashion as opposed to an open operation. It also gives us the opportunity, I think, to do more complex operations that would be difficult to do laparoscopically. In general surgery, we're using it for a wide range of operations, from hernia repairs to gastric bypasses in terms of weight loss surgery, taking out gallbladders, other complex abdominal surgeries, including cancer operations. The Da Vinci affords us the opportunity to accomplish some operations that are really in difficult areas much faster than we would be able to do it in a traditional laparoscopic fashion. Faster, easier recovery with less pain. The ability to do more open have faster recoveries, less pain, and less bleeding.
So there you guys see it in action a little bit there. Um, he did mention that it is considered a minimally invasive surgery. So minimally invasive surgery is kind of a broad term that includes both robotics and endoscopy. Okay, so endoscopy is also kind of a broad term. So using your med term, endo means within. An oscopy is like the viewing of something. So we're viewing inside is what that term literally means. But you have a lot of different types of endoscopy. So just saying endoscopy doesn't necessarily tell you what type of surgery you're doing. You have to have a specific type of oscopy, I guess you could say. So you have gastroscopy, which is EGD. That's where they put the scope down your throat and view into your stomach and really all the way to the duodenum, the first part of the small intestine. Then you have colonoscopy, which the scope will go up the colon the other way. Laparoscopy, lapar means abdomen. So to view inside the abdomen, this one is very common. So you could do a laparoscopy with a robot, I guess you could say. You would just have the different arms or instruments as opposed to your traditional laparoscopic instruments that you see here in this picture. So the robot would give you a little bit more movement of the ends of those instruments. So then you have thoracoscopy that's going to view inside the thorax or the chest cavity, maybe to look outside the lungs, the mediastinum area. You could even do a mediastinoscopy as well. FES we do pretty often, at least around here. It's a functional endoscopic sinus surgery. So it's a shorter scope. It's only going to, it doesn't have to go very far. It's only going up the nose into the sinus, maybe to debride some of the sinus tissue so they can breathe better. Cystoscopy, cysto is bladder, so to view inside the bladder, very common procedure. Take out stones, bladder biopsies, maybe to go up into the kidneys, which would be through a ureteroscopy. So sometimes these are scheduled together, a cystoscopy with a ureteroscopy, say that fast. So the scopes are different lengths because you don't have to go very far to get into the bladder, but to go up through the bladder and into the ureters, it's a much longer distance. So you need a longer ureteroscopy that would really all the way reach up to the kidneys. And then a laryngoscopy is, it kind of looks like what anesthesia uses to intubate with. A laryngoscope is to view the larynx or the voice box. Sometimes we have to do biopsies of the vocal cords, potentially for cancer. And then arthroscopy, arthro just means joint. So this one you might have to get a little bit more specifically, like a knee arthroscopy, shoulder arthroscopy. Those are pretty common to see inside those joint cavities. Okay, so how do we prepare our endoscopic patients? There are some positioning considerations, skin prep, draping considerations. Really just depends on one of those previous things. What are you doing? Where are you looking? Right? So if you're going to go upper abdomen, lower esophagus, it's going to be much different than if you were going to drape or position for a lower abdomen case. Maybe even if it's a lower pelvic, they might have to be in stirrups. Now, if it's upper abdomen, they would not. So those are very important. Even though they're very close in area, the positioning considerations, which would change the draping, is much different. Okay. Thoracoscopy, this could be done supine. It could be done maybe laterally. Just depends on where the surgeon needs to go. Same with like a thoracotomy. You have those different incisions. So it's always important to ask the surgeon what their approach will be. Okay. Also consider conversion for open cases. So things might start as a scope case, an oscopy, but there's always that potential for especially things like laparoscopies, that they will convert to an open case like the laparotomy. So oscopy to view, otomy to cut into, open up. So always be mentally ready for those things, and you will have those supplies available for certain cases, like the laparoscopy. You might have the laparotomy tray available with extra laps and stuff like that to convert just in case. Not everything can be done laparoscopically or any other oscopy. So there's always that potential to open. So here are some of the other pieces of equipment that you will have for your, let's say, laparoscopic cases. Okay, you have to have a monitor. You have to see what you're doing. So our cords to the scopes hook up to these boxes here. You have one that's going to go to the light source so the surgeon can see, right? It illuminates a camera so you get that picture. Okay, in the case of a laparoscopy, you will need to use the insufflator. That is going to use carbon dioxide to put into the abdomen to distend it, and it will gain access. You can have room to work, kind of in this picture here. Otherwise, the belly and the muscles, all of it just lays on those organs. You can't see what you're doing. So the carbon dioxide gas kind of almost makes it look like they're pregnant. Okay, they're kind of puffed up. Suction irrigation, you have to be able to suction, bleeders, you gotta suck out saline, maybe antibiotic saline, and irrigate usually as well. So you have a special instrument or supply that is a suction irrigator that hooks up to that. Diathermy, that's going to be like your Bovie, something that's going to use heat, cauterize, or bipolar. Sometimes they are on a rolling stand like this. It can go from room to room. Sometimes they are just, they're left in the room on what we call a boom that's attached to the ceiling. It can kind of move around the room as needed, but it stays there. Okay. So that is some of your things that you're going to see and hook up throughout the case. So this is not sterile. The cords you have are sterile on your field, but you'll pass off an end to the circulator that will hook up to these machines. So the hooking it up part would not be done by the sterile team. It would be done by the circulator. So you kind of hand it off to them. Okay, so that's kind of the rundown of laparoscopic, endoscopic, robotic surgeries. So if you have any questions on any of that or anything else, as we round up this quarter here, we're almost done. Please reach out to me. Here's my email. Just get in touch and we'll figure it out. Have a good day.